Go ahead and get started. Welcome to today's webinar on Mastering the Nuances of InBrace, part one on clinical approach to InBrace treatment. So today, if you have any questions, feel free to ask any questions in the chat box or in the Q&A, and then I'll be answering them at the very end. Also, at the very end of this webinar, you'll get triggered for a survey. Please answer the survey questions. It's very helpful to us in terms of knowing what content we should be adjusting, as well as what content we should be teaching in the future. So just some background about myself. My name is Robert Lee. I'm the co-inventor of InBrace. I've been with the company since the very beginning with Dr. Pham and then Dr. Tong. And then my current role with the company is I'm the head of clinical affairs and the senior clinical advisor, where my primary roles are to lead the doctor education, advise on product development and clinical protocols, and then manage the clinical case reviews. Some of the educational content that I've worked on in the past are writing our original textbook a few years ago, as well as creating the fundamentals of InBrace mini residency. With Gen 2, I was the principal investigator of the Gen 2 clinical trials when we started working with it in the last few years. And at this point, I've treated, reviewed, or advised on more than 1,000 InBrace cases. Outside of InBrace, I do teach at UCSF. That's where I did my residency. I did my BDS and bachelor's in engineering at UCLA. That's actually how I got involved with John and Dr. Tong to begin with, because they needed my help with a lot of the engineering side of things in the beginning. With John, Dr. Tong, Dr. Andre, our internal team of orthodontists, we published a lot of papers on the topic of digital orthodontics and as well as on InBrace. So over 20 peer-reviewed manuscripts, many of which have made the cover. And then I do practice as an orthodontist still at InStudio, which is our InBrace clinic, as well as Big Smile Orthodontics, which is actually the main clinic of Dr. Tong, who's the main inventor of InBrace. So for this webinar series, the Mastering the Nuances of InBrace series, there's 3 parts to it to begin with, and then we're going to be adding more in the future. The first few webinars are on trying to set the foundation of InBrace, and then as we kind of set the foundation, and I'm confident that everyone knows the general basics of InBrace, then we'll be going into, again, more complicated topics in the future on finishing, troubleshooting, and much more complicated cases that we've been treating. So just to kind of begin, I always kind of like to talk about the nuances of orthodontic treatment. Like while all orthodontic cases are treated with standard mechanics and orthodontic principles, I usually just like to say that each treatment modality has their respective nuances that we have to kind of learn and master as orthodontists to make it predictable and efficient. So with traditional braces, actually, I would say it has the most nuances. If you think about how much we had to learn in residency, where for 2 to 3 years, we had a faculty member at every single one of our appointments, and we had multiple faculty members telling us all the different nuances and tips and tricks that they had on how they approach bracket prescription, arch wire selection, whether they like to repo brackets, switch brackets, flip brackets, all the different auxiliaries that you can add to traditional braces, how you're going to do your wire bending and when you do your wire bending. I mean, there's just a lot of nuances when I think about traditional braces. And then even aligners as well. With aligners, I would say that, gold standard aligner course is, 10, 15, 16 weeks, 20, 30, 40 hours of content, as well as, at the AAO, they have a whole section, a whole column branch blocked off dedicated to aligners. So, the aligners, you have overcorrection, you have your attachment design, your staging, what do you do when things are not tracking? How do you deal with compliance? So there's a lot of nuances with aligners as well. So with InBrace, we have to learn the nuances of how to treat with InBrace. It is a new category, a new modality of orthodontic treatment. So new systems do need to be created compared to traditional braces and clear aligners. Again, I would say that probably like 80–90% of it is what you already know. It's just, again, standard orthodontics. And then you're just trying to recalibrate yourself to doing it with InBrace. So with InBrace and just with any treatment modality, I usually break it down to there's 3 areas of where you need systems set up for to have successful treatment. So first one is your diagnosis and treatment planning, which for us is mainly built into your smile design. Then it's your clinical decision-making throughout treatment. So what decisions are you making at each appointment? When do you move to the next step, for example? When do you add auxiliaries or anything like that? So that's what I call the clinical approach. And then the last part is your hands-on delivery. So, are you bonding things well so that you're not having a lot of bond failure? Are you able to put the wires in efficiently to have a good patient experience? So that's like your general clinical techniques. So today what we'll be going over in this first webinar is in the clinical approach. And then next week, I'll be going over a smile design. And then in the following week, I'll be going through a lot of clinical cases, and in doing so, I'll be discussing the clinical technique in each of the appointments. So to begin with, I like to always make sure that everyone is really firm and strong on their treatment sequence. I would say this is, again, very similar to your base foundation with traditional braces, where with all of us with traditional braces, we have our general wire sequence. We know where we place our brackets. And then whatever you do in your traditional braces cases, it almost always still follows that general sequence. You might add to it, you might have to adjust it a little bit, but you still always can fall back on, this is the sequence I follow in just about every single case. So whether it's an easy case or a hard case with InBrace, I still always follow the sequence, and I just have to add and adjust to it as needed. Where you can break it down again into stages: stage 1, stage 2, and digital enhancement. And within each stage, you have its respective smart wires. So in stage 1 has smart wire 1, stage 2 has smart wire 2 and 3, and digital enhancement has smart wire 1, 2, or 3. It comes back to the numbering of the smart wire essentially comes back to the force and the size of the wire. So as you increase in the size of the wire, you're going to increase in the size and the strength of the wire. So with digital enhancement, you're getting additional smart wires. It's still the same size as the 1, 2, and 3 from stage 1 and 2. The only difference is that you're designing it based on a new smile design. So with stage 1, the purpose of stage 1 is to complete your initial leveling and aligning, allowing for easy insertion of smart wire 2. I always think of this as kind of like the same as my initial 014, 016 round NiTi wire that you're going to use to unravel your crowding, kind of resolve most of the rotations, and then you can get your brackets on in the right spot. And then smart wire 2, or stage 2, is kind of when you're ready to go to your larger rectangular NiTi wire, and then maybe you're ready to even start running some elastics to kind of work out most of your inner arch discrepancies. That's kind of the purpose of stage 2. This is what I often will call as like the working phase of orthodontics, where again, the purpose is completing your intra-arch leveling and aligning, and then resolving your inner arch discrepancy. So fixing your vertical, AP, and your transverse, running your elastics. And then if needed, you can go to your final detailing stage. So, with traditional orthodontics, this is when you might be doing your wire bending. So that's what digital enhancement's purpose generally is for your final detailing, if you need that. So I like to always break down then each one even further so that you know exactly what to do in each appointment. That's one of the, I would say, the general feedback that we've gotten as we've done clinical reviews with many doctors over the years is they don't know what they should be looking for, and they don't know what they should be doing at each appointment. So again, if you understand the stage 1, stage 2, and TE goals, then you kind of always know what you should be doing at each appointment and what you should be doing in the next, what you should be planning for in the next visit as well. So in the stage 1 goals, the first and main goal, I would say, is to get the brackets in what we call the planned bracket position. We call it the planned bracket position because all of this is digitally planned. So after you approve your smile design, what we go and do is we will then virtually place the brackets on the approved smile design. And then based on the bracket position, we actually will then design the wire. So that means any bracket that is deviated from that planned bracket position or like ideal bracket position, it's not going to work with the design smart wire that we've created for you. The second goal is to perform any IPR if recommended. That usually is just to help unravel the crowding, also to mitigate any relative intrusion from unraveling of crowding. And then the last goal is, once again, you've achieved goal number 1, which is, I would say, the main thing and one of the main purposes of this webinar. Then you allow the smart wire 1 to fully express to complete your initial leveling and aligning. So when you start your case, the first thing you would do is you would look at your treatment instructions. So this is provided for you in your kit, as well as it's online on the portal. And then you would look at your treatment instructions and see, do you have any brackets that are teeth that are like blocked out? That's what the teeth shown in green. Or are there any brackets that are placed off-center, the ones shown in like teal? And so you have to always remember the lingual arch form is narrower than the labial arch form. So brackets that you think, oh, I would be able to get that on very easily on the buccal, doesn't necessarily translate to the lingual, just because the brackets there's the buccal lingual thickness to the brackets. So as you can see here in the lower, the brackets would be colliding in those areas with the green teeth. It also show your IPR that's prescribed, as well as if there's any expected collisions. So let's look at a very simple example. In this example, all the brackets started gray in the treatment instructions. It doesn't indicate for any brackets that need to be repositioned or direct bonded in any way. So in this case, essentially once you do your fitting, you put the brackets on, you've already achieved your first goal, which is get all the brackets in the planned bracket position, because they were all indirect bonded to that point. And then we performed all the IPR in this visit as well. So that technically takes care of your second goal. So the only remaining goal is you let the wires fully express. In a case like this with minor crowding, it's just one appointment cycle. So roughly about 8 weeks, 2 months is our general appointment cycle. So when the patient came back 2 months later, alignment is essentially done. We can go to upper and lower smart wire 2, and then we can run any inter-arch elastics if needed. So we get this question a lot, is when do you do the IPR? Because a lot of people are very familiar with aligners, and with aligners, they will say, do this IPR at this stage and at this stage. So our general recommendation is you should just do it during stage 1. So you just do it earlier on in treatment, generally because it helps unravel the crowding if you have any crowding. And also because with open bite tendency cases, you're going to get proclination and relative intrusion. And then that could tend to an opening of the bite. With InBrace, I would just say I would say proactively try to prevent this as much as you can, just because, patients don't like having buttons on the front of their teeth. So if I can ever avoid the need to run any anterior elastics by being a little bit more proactive with doing IPR earlier, as well as in my overcorrection, then I definitely always try to do that and recommend that. So in a case like this, for example, where the patient told me, I'm not going to wear anything on the upper, I'm only going to have InBrace on the lower, I'm also not going to wear any elastics. So just make sure not to make my bite worse. It's okay, that's no problem. I just have to, as long as you're okay with me doing a good amount of IPR in the beginning. So in this case here, I did a lot of IPR on delivery of InBrace on the lower, just to make sure I don't have any flaring of the teeth forward. And a few months later, I was able to unravel the crowding. At least I was able to maintain the overbite and not make it worse. So let's look at a little bit more complicated example now. So in this case here, the upper lateral incisors start off-centered. The lower left one starts blocked out. And then the upper anterior teeth also are going to be in collision. So with the upper lateral incisors, normally the off-centered brackets you're going to be able to resolve them in the following appointments. So you'll see in the next appointment, we're going to reposition them. And that's what we have planned for in the next visit. The lower left one, we actually were able to direct bond that on delivery. So the reason why it wasn't included in the indirect bonding tray is because with an indirect bonding tray, you have the thickness of the wall that have to hold the bracket. So if you kind of look at the bracket position of the lower left one, it's like right up against that lower right one. There wouldn't have been able to material to actually keep the bracket within the well. And so that's why while you may be able to direct bond it because you don't have to deal with that thickness of the wall, we weren't able to indirect bond it. So usually they can direct bond a bracket. I encourage go ahead and direct bond the bracket to begin with. So in this case, we direct bonded the bracket. Sometimes that wire is a little bit harder to engage when it's so tight in that space. So that's when we use we recommend using freeze spray to make the wire dead soft because it's a heat activated wire. And then you can place, because it's indicated that there's going to be some collisions, we could place bite turbos would likely be needed in this case. So when this patient came back 2 months later for their next visit, with the upper lateral incisors, you can see that a lot of space has been created. So now we were able to reposition those brackets to the center of the teeth via direct bonding. And then usually any bracket that you direct bond, I always recommend you double check your direct bonding, especially in the beginning while you're getting your bearings on using InBrace brackets. Once you kind of get used to it, I would say, it's like for myself, for example, I pretty rarely would ever need to reposition it again. But usually in the first few cases, as you're kind of getting used to direct bonding brackets on the back of the teeth, sometimes you have to reposition it more than once. So I always just recommend everyone always double check your direct bonded bracket. So upper twos were repositioned in this appointment. Lower left one was double checked. The alignment on the lower looks really great. So then we know, okay, we don't need to reposition it again. So I'll make a note in my chart that's good. And in the next visit, we're going to check the upper laterals again. So even though, and in this case, the upper lateral brackets look great, the alignment looks really nice. So at this point, all the brackets have been now direct bonded into what we consider the planned bracket position. All the IPR has been performed. The wire is now expressed to these bracket positions for the last 2 months. And so now we're ready to go to smart wire 2 at stage 2 and then run any interarch elastics if needed. Okay, so let's look now at a little bit more blocked out 2. So now in this case here, the lower left 2 was blocked out to an extent where the bracket couldn't be put on to begin with. So then in this case, we directional bonded the smart wire, which means we glued the wire to the tooth. Now, we call it directional bonding rather than just saying just bond the wire to the tooth. We added that word directional in front of it just to re-emphasize to people, you're not just putting it on randomly. You should be putting it on in a place that activates the wire. So usually I just tell people, you kind of think about if you had a lingual button and you put a lingual button on this spot, or you wanted to put the bracket in this, where would you put the bracket? In this case, you would put the bracket as distal as you could because you're trying to rotate the distal in. So you want to activate the IP loops by bringing that locket again as distally as you can. So you want to put some direction or directional thought behind where you're bonding the wire to the tooth. So then 2 months later, when the patient comes back, we have a little bit more space, and then we're able to bond a bracket. So we direct bonded the lower left tooth bracket. We perform the remaining lower IPR. So the goal of doing your IPR has been completed. And then when the patient comes back in the next visit, we double check the lower left tooth bracket positioning. Again, in this case, the bracket positioning looks good. So then now you're ready to move on to stage 2 and run any elastics. So with dealing with blocked out teeth, we have 3 traditional ways that we've been dealing with it. We can either leave it unligated, we can add the directional bonding as we showed, or we can direct bond a bracket. And then many of you also may be seeing that we have new specialty smart wires that are coming out. So as we're doing the rollout, you'll see that we're taking steps to make this easier and easier and making it more and more automated for everyone. But for now, going over, I would say, the traditional approach to directional bonding. You would do your standard bonding steps where you isolate, etch, and prime the lingual surface of the tooth.
Hey, Doctor.
Yes.
Before we go on, Dr. Kwong had a quick question
Sure.
earlier, I think a slide or two ago. Where did he put? Oh, he says, I think he missed something earlier. Why did you end up repositioning the upper tooths?
Oh, sure. Yeah, so the upper laterals, in this case here, you have the brackets and teal. So they're actually started in an off-centered position. So because they started in an off-centered position, so we couldn't get it quite in the center of the tooth, then we need to reposition them more to the center of the tooth, which is, again, what we call the planned bracket position. So there's 2 types of direct bonded brackets, 2 types of reasons why you would need a direct bonded bracket. Either the bracket was not put on to begin with, or we purposely place it off-center so that you can get a bracket on, and then usually within 1 appointment, you can then reposition the bracket to the planned bracket position in the center of the tooth. Okay, so with directional bonding, again, you follow your standard directional bonding approach, where our bonding technique, where you isolate, etch, prime the lingual surface of the tooth. There's different ways of doing directional bonding. This is the way that we found works, I would say, the easiest, I would say, where because it's heat activated, you can cool down the wire with freeze spray for about 5 seconds. Sometimes I have to do this more than once as I'm positioning the locket, because then you'll position the locket with the engager. You know, if it's not going exactly where you want it, sometimes you need to re-cool it down with, you just put it on a Q-tip, a microbrush, or a cotton roll. Once it's positioned where you want it, you can add some flowable composite between the locket and the tooth, as well as on top of the core and the neck. We found that we really like these blue etch tips. So these are a thinner lumen. When you use the traditional lumen size of a flowable composite syringe, it actually is quite big. So sometimes I would say it gets everywhere. You have to push a lot harder with this blue tip, but it gives it a lot more controlled amount. It expresses it in a much smaller amount. So I found that it makes it a lot more controlled when I'm doing this. Once I have the flowable composite on, usually I'll do the initial cure from about 2 inches away. So it's literally outside of the mouth. Because it's heat activated, if you do the light cure right next to it, it'll actually pull away the wire. It'll activate the wire will pull off, and then it'll debond. So usually I tell people, light cure from quite far away for 10 seconds, come in slowly as it's curing, and then go in and do your final cure. And that will get you a successfully directional bonded smart wire locket. I have had some people, I would say, struggle with that step E. So what a lot of my assistants have found helps them a lot is they can then hold it in place using Explorer. So while the flowable composite is uncured, still wet, they'll take it a thin Explorer, they'll just push on it passively just to hold it in place, and then they'll light cure like that. And then when you're ready to remove the directional bonding, the main thing I just tell people is kind of focus on not hitting this neck area. This neck area is what you use to take the wire in and out. So I focus most of the composite removal on the core area below the neck. Sometimes I'll just lightly go over this area. And then when most of it's off, then I'll just use a scaler to flick it off. If it's not coming off when I'm trying to flick it off, then I'll go back and remove a little bit more composite. But again, just main thing is just be a little bit careful of this neck region because you don't want to damage it. And then once it's flicked off, it's fairly straightforward. I usually just grab a wine guard, break off any remaining composite on the locket, and then I take off the composite off the tooth. Okay, so let's look at a case that has a little bit more crowding now. So in a case like this, the lower right 3 was too blocked out for me to put a bracket on to begin with, or to even directional bond it. The lower left one, I directional bonded the smart wire locket, and then the lower right one started in an off-centered position. You can see it's more mesially than planned. We also performed some lower IPR in this appointment to help kind of unravel the crowding. When the patient came back about 2 months later, a little bit more space has been created for lower right 3. So then I was able to directional bond the smart wire locket onto it. The lower left one and the lower right one now have aligned to a place where I can get the brackets on properly. So then I repositioned the lower right one, and then the lower left one, I direct bonded a bracket. And then I continue to perform some more lower IPR as I'm trying to unravel this crowding. So the lower right 3 essentially at this point becomes your rate limiting step in stage 1. So I checked the lower left one, lower right one bracket position again. Just always double check at least once. In this case, I'm like, okay, the alignment looks good. I don't need to reposition those or worry about those again. But the lower right 3, when I direct bonded it, I made a note in the chart. Okay, I direct bonded this off-centered. I know that I need to reposition this the next visit. So when the patient came back to the next visit, my staff was already set up for it. And then we direct bond the lower right 3. At this point, I felt, okay, I got it pretty much in the center of the tooth. So I think that at this point, I should be good going forward. So when the patient came back at 8 months, I felt the alignment was sufficient. And then the bracket position was good enough. And then I'll be moving forward into stage 2 at this point. So usually with direct bonding, we recommend only reposition brackets that are indicated to be direct bonded. You should not be repositioning indirect bonded brackets because with indirect bonded brackets, it's really hard to get the right buccolingual thickness. It's really hard to get the right torque of it. So we just recommend, again, only reposition brackets that are direct bonded. It's impossible to get the direct bonding, perfect. So I always just tell people, as long as it's just a little bit off, a minor inaccuracy, it's totally acceptable. You can fix that very easily in digital enhancement if needed. If it's really off, if you left it way off mesial or way off distal or way occlusal or way gingival, then that should be repositioned because that probably you're going to see unplanned tooth movement where it's not moving as projected, as well as it can even compromise our fabrication process of the digital enhancement wires. So with direct bonding brackets, we do provide a bracket positioning guide. So it's provided in all of your kits as well as it's available on your portal. However, I honestly just find that it's fairly straightforward and very intuitive, where you place it along the long axis of the tooth, you place it in the center of the tooth mesial distally. With occlusal gingival, you just place it, you look at the adjacent brackets, and then buccolingually, you just don't push it fully against the tooth. So kind of going through that more in depth with the mesial distal position, again, place it in the center. The one difference that I like to make sure that people are aware of with lingual bracket positioning is that it's opposite of buccal in terms of rotations, where on the buccal, if you move a bracket more mesially, we know that's going to cause a mesial out rotation. While on the lingual, it does the opposite. If you move a bracket more lingually on the moving a bracket more lingually, like more mesially on the lingual, then that's actually going to result in a mesial in rotation. So it does the opposite effect when you work on the lingual. So I always like to let people know, if you have a bracket that's more mesially planned, so more mesial than the center of the tooth, you're going to end up with some mesial in rotation. If you have a bracket more distally than planned, you're going to end up having more distal in rotation than you expect. So looking at this case, for example, if you look at the lower right 3, the lower right 3 had to be placed off-centered. It's placed more distally than expected. So we're going to move the bracket more mesially. And I think that's also just intuitive. Like if say, for example, you're trying to deal with this rotation and you had a lingual button, like you would move the lingual button more mesially as you're trying to rotate the tooth. So it's just, I would say, basic biomechanics. So as this tooth expresses, you can see 2 months later, the tooth still has excessive distal in rotation because, again, the bracket was more distal than planned. So that's why when the patient came back 2 months later, I actually repositioned the bracket more mesially. And then going forward from here, it should resolve fairly predictably. So with the occlusal gingival bracket position, it's the same, I would say, as with traditional braces. In this case, for example, here on the lower left one, you can see the incisal show above the bracket. The lower left one has way less, and that's why it caused a step down, essentially. It caused intrusion. So when I saw that, I just repositioned the bracket more gingivally. And so within, a month, that pretty much resolves that. So again, with occlusal gingival bracket position, again, just make sure it's similar to the adjacent brackets. You know, in clinical review, we've seen hundreds, thousands of cases, and we see them all over the place. So that's why it is important, again, just use, again, basic orthodontic bracket positioning mechanics, and then it should work out pretty well for everyone. The last thing, I would say one of the other differences is the buccal lingual position. This one's probably the hardest to get exactly correct. So I always tell people, you know, don't have to sweat it too much. The main thing is that with a indirect bonded bracket, you know, that's digitally planned, you can kind of see it on the lower fours in this example. We can't put it right up against the tooth. Like when you do with traditional brackets, you'll push the bracket right up against the tooth and you get all the flash exude around it. So when you're planning on the computer, you don't quite get it as close. So because of it, there's a little bit of a thickness to the composite base. So with the buccal lingual bracket positioning, I just say, just lightly press against it firmly, but lightly. And, you know, exude some flash, but not all of it, because you're trying to leave a slight composite base. You know, if it is a little bit off, it's not the end of the world. So like in this case here, the lower right one was directional bonded. I then put a bracket on. Because again, I pushed a little bit too hard on it, you know, it makes the bracket end up a little bit more labially positioned. So then it's going to end up expressing to be more lingual movement. And then you get a slight step. So again, this is very easy to fix in digital enhancement. It's just if you wanted to get it a little bit better during your stage 1 and stage 2 as the initial wires unravel. But the most important thing, again, to me is that the brackets are roughly centered in the tooth mesial distally. I would say that's like number 1. And then also occlusal gingivally, so that's not having to create such a large step in the wire as you're doing as the digital enhancement wires are fabricated. So again, most important thing to me in stage 1, getting the brackets in the planned bracket position. We see in clinical review, that probably is like number 1 or number 2 of the reason why the teeth aren't moving as planned and is causing cases to go longer than expected. Okay, so moving to stage 2, stage 2 goals are to allow your SmartWire 2 and or SmartWire 3 to express, resolve, nearly resolve or accept any interarch discrepancies, and then remove or reduce the bite dribbles if needed. So I'd say the main one here is resolving your interarch discrepancies. So running the elastics that you need to finish the case out. So with elastic shrink guidelines, the general recommendations we provide are with SmartWire 1, use light elastic, SmartWire 2, medium, SmartWire 3, heavy. Most patients, I would say you finish in SmartWire 2, you don't need SmartWire 3. We'll go over when and why you would use SmartWire 3. So the majority of cases that we treat, we use light and medium elastics. And the reasoning behind keeping it a little bit lighter is, you know, instead of having a rigid, straight stainless steel arch wire that I would say mitigates or kind of prevents any side effects that you'd have, you know, you're running elastics on a NiTi wire that has loops in between it, which adds more flexibility to the system. So you just don't have that rigidity. So that's why you keep it lighter to try to mitigate side effects, as well as in the next week's webinar, we'll be going over smile design and how do you add in the overcorrections to say counteract any of your expected side effects. So looking at an example, you know, in this case, in the post-fitting on the left-hand image, you know, upper right 5 was fairly rotated. So we added some buttons to derotate it. We got a bracket on at the 2-month visit. At 4 months, I actually started doing some light class 2 elastics. That way, as that, again, continues to derotate, we're using that space and bringing back the upper. So again, light elastics, 3/16 inch, 2.5 ounces, because we have SmartWire 1 on the upper. SmartWire 2 we have on the lower, just because there was less going on the lower. And then when the patient came back 2 months later, we were able to get a bracket when what I was thinking would be the planned bracket position on the upper right 5. So we engaged upper SmartWire 2. Patient still slightly class 2, so I switched to medium strength elastics, was wearing it full time. And then when the patient came back 2 months later, I took records for DE. So class 2 discrepancy is pretty much resolved. We've let the wire express for about 2 months. And then I know that, you know, the wire might continue to express a little bit while the DE is fabricating. It usually takes, you know, 4 or 5 week turnaround time. I usually bring back a patient 6 weeks later to get their DE wires. We took records. So I usually like to take a pano at that when I take DE records, just to make sure I can adjust any root angulations as needed. If you're wondering how we resolved that rotation on the upper right 5, we just bonded lingual, we just used buttons. So I had buckle buttons, upper right 5, upper right 6, and I ran power chain. On the lingual, I ran it from upper right 5 to the upper right 4. You can run power chain to the InBrace brackets. You just add it on top of, you place it over the gingival tab of the bracket of the upper right 4 in this case, and then you add the locket on top of it to kind of lock the power chain in. I only recommend really using power chain for this general reason for rotations. Usually it doesn't really help too much, I would say, with space closure at the end, because you're going to be in the larger wires, and that it doesn't, the power chain doesn't overpower the IP loop. But in this case here, it works really well. I also don't recommend using power chain in the larger wires because it's going in between your locking spring of the bracket and the locket. And, it's an elastic, essentially piece like of a rubber. It kind of almost acts like a shock absorber. So when you're trying to disengage the wire, it's quite hard to disengage it when you have a SmartWire 2 or 3 in, because they're larger wires. With SmartWire 1, though, I find it's fairly straightforward to still take the wire out with the power chain. So in stage 1, and at 2 months, then we were actually able to get a bracket on the upper right 5. So I just placed it. I knew it was going to be off-centered. So then when they came back 4 months later, I repositioned it again more distally. At this point, I felt like I actually got it pretty much in the center of the tooth. And then when they came back at 6 months, I felt like the rotation was mostly done. So then we can now move on to SmartWire 2. So with vertical elastic wear, I actually recommend lightening it up a little bit more. So SmartWire 1 don't normally run elastics unless you have a very high canine or like a high tooth that you're really trying to bring down. Light elastics, SmartWire 2. So I would say most of my vertical correction I do with light elastics. And then SmartWire 3, you can run medium if needed. The reason why, again, it comes back to you have instead of having a rigid stainless steel straight arch wire, you have a NiTi wire with loops in between it. So if you overpower the vertical elastics, instead of trying to, like, I would say, extrude maybe upper 2 to 2 as kind of a unit to fix an open bite, you're going to just extrude that single tooth the buttons on. It's just will overpower the loops, maintaining the vertical. So that's why, again, we just recommend generally doing it light. And if you're going to run it in SmartWire 1, it's usually for a tooth that you actually are trying to just extrude that individual tooth. So here's an example for vertical. So in the beginning, patient's class 3-ish, put the upper on in the first appointment, put the lower on in the second appointment, ran class 3 elastics just at nighttime, light elastics, because again, we're in SmartWire 1. And then when stage 1 was complete, at 5 months, we put in upper and lower SmartWire 2. At this point, I wanted to bring the upper canine down a little bit more and kind of run some vertical elastics. So I just changed it to a sling pattern, where now it's going from upper 6 down to the lower 3, back up to the upper 3. Because I'm adding still like a vertical component, instead of moving the medium strength elastics for class 3, I still kept it light. I just did a longer one. So it's a 5/16 inch, 2.5 ounce elastic for, again, keeping it light because there's a vertical component. And then so when the patient came back a few months later, bite looks good to me now. Wire's been expressed for a few months. There's no real bite turbos at this point. You can see the occlusion is in place. So then I took the e-records, again, another pano, tooth print, and photos. So one question that I get a lot is, when do you use SmartWire 3? Should I be using SmartWire 3 in all my cases? And I would say generally I consider it more of an optional wire. I only really use it maybe in, like, I would say 10% of my cases, 5-10% of my cases. So one reason I may use it is if I'm trying to run heavier elastics or long-term elastics. So for example, if I'm using like a carry motion appliance and then I added it on, so say I instead of doing like sagittal first, I'm doing it during InBrace treatment, and I have lower InBrace on, like in this example on the left, I'm going to want to go to a SmartWire 3 on the lower to try to mitigate some of the side effects of the flaring that you're going to get with class 2 elastics, especially with the carry motion appliance that runs very, very heavy elastics. While on the right-hand image, you have a 2 millimeter quarter cut class 2 case. With this one, medium strength elastics would be totally sufficient to resolve it. So you wouldn't need to go to SmartWire 3 in a case like this. The other reasons why you would use SmartWire 3 is to express tooth movements that require additional force. So like transverse expansion, leveling a deep curvous fee, upper 2 to 2 torque expression. So in a case here, like here on the left-hand side, where you're trying to do a full arch expansion, expanding the full posterior upper 4 to 7, you're probably going to add some overcorrection. You might need to support it with cross elastics, and you might want to go to SmartWire 3 in this case to get some additional force for the expansion. While the right-hand image, you're trying to expand 4, 5, and 6, but the 3 and the 7 are buccally displaced. So because it's going to be reciprocal, like favorable tooth movements where the 3 and the 7 will come in, 4, 5, and 6 will come out, usually this will express very predictably. You wouldn't need to add any overcorrection here, and then you could probably, this will also just express the SmartWire 2. For a deep curvous fee, Gen 2, I would say, has proven to us that it's pretty good at leveling a curvous fee if you have the proper overcorrection and just with SmartWire 2. However, if you're finding that you're having a curvous fee that does not level, that's when you would go to a SmartWire 3 to add additional force to it. So on the left-hand side, I would say you potentially may need to go to SmartWire 3 because you have a deep curvous fee with very mild crowding. And then the crowding as it unravels will relatively intrude and help level your curvus T. So that's why on the right-hand image, because there's more crowding and I expect that these teeth are going to come forward and relatively intrude, you might not end up needing it. Smart wire 2 might be sufficient for this one. And then with upper 2-to-2 torque expression, when you have retroclined upper incisors and you're trying to get more torque, especially when you also have spaces that, with spacing, you're going to get more relative intrusion, or sorry, relative more retroclination with the space closure. So the one on the left-hand side, most likely you're going to need a good amount of overcorrection to the torque. Plus, you're going to probably need to go to smart wire 3. While the one on the right, you have crowding, the upper laterals are actually sticking out. So as the upper laterals come in, the upper ones are going to come out favorably. Most likely you wouldn't need to go to smart wire 3 in a case like this. Okay, so now we've talked about smart wire expression. We talked about the interarch discrepancies. Those were the first 2 goals of stage 2. The last one deals with bite turbos. So with bite turbos, most likely you'll have placed them in the very beginning of treatment. Again, with the treatment instructions, it will indicate whether there are collisions or not. There's 2 different types of bite turbos we'll recommend. You either use the flexible anterior bite turbos with Teleo or Firmit. Firmit was the product that we used traditionally, and then that was discontinued. Teleo is the successor to Firmit, pretty much the same thing. Both are by Ivoclar. And then you have posterior bite turbos, which is the same as I would say traditionally done. We always just tell people, be a little bit more deliberate with your bite turbo placement with InBrace. I would say a lot of providers are so used to just always placing posterior bite turbos, they just always place posterior bite turbos, and they just use that with InBrace. But I would just say this nuance, this being a little bit more deliberate here, usually will make your cases go a little bit more predictably. So with flexible bite turbos, anterior bite turbos we just recommend for deep bite cases. If you have retroclined upper incisors or a larger overjet, then we'll place it on the upper canines. With posterior bite turbos, generally we recommend to place it on the upper teeth. If you place it on the lower, you might tend to still like the bite turbo might actually collide with the InBrace bracket on the upper. So that's why we tend to find if you place it on the upper 6s or the upper 7s, that usually is I would say the most predictable way of doing it, that you're not going to get collision still. I do like to always recommend for everyone, make sure to place bite turbos. Don't let the patients bite on the brackets. It's kind of similar to having it biting on, say, like a ceramic bracket. When your patients bite on your ceramic brackets, they start wearing the incisal edges or they're wearing their enamel. So we have seen that if they are constantly biting on the brackets over time, it can cause some enamel wear. When you are ready to do your digital enhancement for detailing, in theory, you shouldn't really be needing very many bite turbos. Your bite should be to the point where the occlusion can be evaluated properly, and you're just trying to do your final settling. So in this case, with the posterior bite turbos on the right, this patient is probably not ready for detailing or final detailing yet because we have a bite turbo on there. You can't really evaluate the bite. And if you can't really evaluate the bite, you can't really properly plan your settling in your digital enhancement smile design. And then same with the flexible anterior bite turbos on the left-hand side, the way that we design the wires in digital enhancement is we will look at the brackets and then we'll create the wire exactly for where the bracket is placed. Now, if we can't see the bracket, then we have to guess where it is. So we have to actually put a new bracket on. And then when we put a new bracket on, that then translates to you have to then reposition the bracket to where we have placed the new virtual bracket. Because again, the wire is designed exactly where we have the bracket virtually. So if you are going to have, if you still do need bite turbos, because there are cases where you have short clinical crowns that you just need to have bite turbos on all the time, you should remove them, particularly the flexible bite turbos. You need to remove them prior to the scan for the tooth print, and then you put a new one. You replace it with new flexible bite turbos, and they're very easy to place. So we have a great video on the knowledge base on how to place them. They're really easy to take off because you can just peel them off, and then to put them on, it just takes 30 seconds a minute to put them on. So that goes over again your stage 2 goals, where again you let the wires express, you nearly resolve, accept your interarch discrepancies, and you remove or reduce the bite turbo so that you can see the proper occlusion when you're doing the DE smile design. And then once those are complete, you're either generally ready to finish treatment or proceed to digital enhancement. And with digital enhancement, the first main thing you're doing is you're adjusting the smile design. So you're making any finishing improvements, you're addressing any side effects that happened. If there's any spaces that opened up or were residual, you'll make sure to close those. You'll add any overcorrection. And then the last one is that you'll assess and request for any bracket position adjustment if needed, and we'll be going over why you may need to do that. And then you're going to go through and add your final finishing adjustments. So you might need to reposition some brackets, you perform any IPR, these would all be in your DE instructions. And then you might do just some final general finishing things like enameloplasty or equilibration or adding some like buildups or something of that nature. And then you let the wire express and then run any settling elastics if needed. Sometimes people, you lose tracking in the beginning, kind of like a mid-course correction with aligners. So if you lost tracking, something is not moving as planned, and your stage 1, stage 2 goals have not been completed, it's totally fine to submit for an early digital enhancement or like a mid-course enhancement. So I mean, your options are here if if actually it's just like you had a wire broken or you had some brackets debonded. You don't need to go through a digital enhancement for that reason. You can just item request for any replacement parts. But if something has really gone off course for whatever reason, your original small design wasn't done properly, or you're changing your treatment plan, then you can always submit for like a mid-course digital enhancement. And then you would just adjust your small design as needed at that point. So when you are submitting for digital enhancement, it's really important, again, to provide a really good tooth print, to have a very clear scan of every single one of your brackets. If you have a bracket, completely covered with soft flow or again, the flexible biturbo telio material, then again, we can't see this bracket. So we can't make a wire for it based on your current bracket position. So what we'll do is we'll digitally remove your bracket and place a new bracket for you. And then we would then send you an indirect bonding tray to reposition it, which is more chair time for you. So that's why I always tell every one of my staff members, this is for a DE. So because this is for a DE, they know that they need to be able to very clearly see every bracket like this in their scan. If they are not like air drying it and there's still saliva on the brackets, you get things like this happen where the bracket is not clearly scanned. And again, we can't see exactly where this bracket is. So we have to then digitally remove it and place a new bracket on for you. Again, that results in more chair time for you. And also it makes it more inaccurate because you're going through another bonding process. You can leave the wire in during the scan. That doesn't bother us at all. So that saves you some chair time and not having to take the wire out when you do your DE scan. When you do your DE small design process, I'll be going over this a lot more in detail, I would say next week, but I always just recommend a general less is more approach, where with traditional braces, when you're doing your final detailing, you don't detail bend every single tooth. You detail bend just the tooth that you need to, and you leave everything else stable, because every detail bend you do actually does create reactionary forces. So same thing with the small design. I always tell everyone the DE small design is essentially your wire bending that you're doing, because as you move teeth, you are essentially adjusting the small design, or you're essentially adjusting the smart wire design. So we're going to go over this 5-step approach next week. Usually when you're at your final detailing stage in DE, you can kind of just skip forward and you can probably just do the last step, where you're just kind of looking at your detail bends of the small wire. So I always look at it from the lingual view when I'm doing my DE final detailing. And I just make sure that the bracket position change between malocclusion and small design is essentially how I would do a wire bend. So if you were to imagine, this is the original small design that I submitted, the malocclusion I submitted, and this is what the small design looks like. This is how the wire is going to be designed. And then when I put this wire in to the malocclusion, it's going to want to then bring this tooth down. So that's a step down bend essentially. The other thing you should be looking at in your DE small design is the bracket position. So in theory, or in practice, you should have gotten all the brackets in the planned bracket position in small wire 1 in stage 1. However, even myself, sometimes I just miss it, or I just didn't see it during the process. So when I do get the DE, and I've already submitted it and I'm already looking at the small design, I'm like, oh shoot, one of my brackets is way off. Then what you can do is you can just request for the bracket to be virtually repositioned, and then we'll put it in the center of the tooth for you, and then send you a single tooth indirect bonding tray if there's space to place the single tooth IDB tray. If the tooth is still really rotated, then we can't create an IDB tray if it's too rotated. But you can see in these cases here, like on the left, the lower left 3 bracket is way off to the distal. And then the right image, the lower left one is way off to the, is way off to the, needs to be positioned more distally. So when the brackets again are way off center, I usually just kind of like it to traditional braces. If you were to put a bracket on traditional braces way off to the center, so way off to the distal or way off to the mesial, can you align the teeth? Yeah, we can, but you'd have to put a huge bend in the wire. And it just makes it a lot more, I would say it creates a lot more uncertainty into the mechanics of what you're trying to do. So same thing here. If you were to put the bracket, if you leave this bracket way off to one side, it is possible to align the tooth, but you'd have to add some overcorrection into it. Just like with a traditional wire, you'd have to add a huge overcorrection bend to get that way off center bracket aligned. So for example, and then again, so I've gotten a lot of pushback on this concept. So this is the example I generally show where, this bracket is way off to the distal. And so the wire is technically designed for this bracket position. It does improve things. So you can see that the alignment actually does significantly improve. What I found though is because the bracket's not centered, that last like 5 to 10% of getting that last bit of rotation doesn't express that predictably unless you added some overcorrection to it. But to now have to add overcorrection to this system, you're adding, I would say, uncertainty, where it's just a lot easier if the bracket was in the center. When the bracket's in the center, the wire is going to design as planned, and then it'll be able to do the rotations much more easily.
Hey, Dr. Lee,
Yes.
we got a question here that whenever you submit for a DE, do you have to request for a new bracket position? Or will we notify them and make a recommendation?
So we will only, so our internal team will only reposition it for you if there's a problem with fabrication. So sometimes when the brackets are super close together, so if you can imagine like, if these brackets were so close together, we can't form an IP loop because there is a minimum width we need for an IP loop. Then what we will reposition it for you. We'll send in the DE instructions. Hey, we had to reposition it, and we'll provide you an indirect bonding tray. So the only reasons that our internal team will currently reposition the bracket for you is if there's a problem with the fabrication process. From a clinical perspective, they won't be doing that for you at this time. So if you do see a case like this, so again, they were able to make a wire for you for this provider in this case. Because they can make the wire, they're not going to reposition it. We're not going to force the reposition. So in this case, it would be up to the provider to state, oh, actually, I noticed that this bracket is off-centered. So I'm going to want to then reposition it to the center. So usually I tell people, if you have a bracket that's off-centered and the alignment is off, you should request for it to be repositioned in digital enhancement. If it's off-centered, but the alignment's fine, then you don't need to reposition it because your alignment's fine. So again, any major inaccuracy, again, where your bracket's way off to one side, that you should, again, reposition. And that is going to result in unplanned or movement that's not going to express properly. Again, if it's a minor inaccuracy, as long as you get it roughly in the center of the tooth, then that's acceptable. It should be able to rotate the tooth with no problems. Okay, so with digital enhancement and general clinical adjustments, you're going to get a DE SmartWire 1 and a DE SmartWire 2 in your kit. So again, we just always send the 2 wires out as a standard. The DE SmartWire 1 is kind of for your mid-course enhancements, where like if, for example, you had to stop midway through, you haven't finished your stage 1 and stage 2 goals yet, you're still in SmartWire 1, but you were changing treatment plan or there's something that wasn't tracking properly. That's why we provide the DE SmartWire 1. When you're actually in your finishing, you just start with SmartWire 2. So I'd say almost all of my cases, I just start with DE SmartWire 2. I almost never use DE SmartWire 1. DE SmartWire 3 is not provided because most of the time your major mechanics should have already been performed. And again, SmartWire 3 I'm only using in very select situations, but it is available by item request. So if you ever need it for any reason, you can item request for it. So general approach when you're trying to finish your treatment with digital enhancement, engage your upper and lower digital enhancement SmartWire 2. For minor movements, rotations in and out, small space closure, that should express within your first appointment cycle, 6 to 8 weeks. If you're trying to express some more root movements, sometimes it takes a little bit longer. So usually I might delay it for another appointment. So 12, 16 weeks for any root movements for final detailing. If you have to do a second DE, not the end of the world. I would say it's pretty similar to, when you're doing your wire bending, sometimes you do it a little bit too much, sometimes you do a little bit too little, sometimes you miss, oh, actually I need to do a detail bend on this tooth. So sometimes you have to do a second digital enhancement for that reason to increase or decrease the amount of detailing you did. A lot of times I have found that this can be avoided with like active retainers or reshaping the anatomy. So, sometimes when I have still a minor rotation or I have an incisal edge that's not perfectly level, I just tell the patient, I can just smooth that out for you. Or, we can do a digital enhancement, but, it takes, 4 or 6 weeks to fabricate and turn around and for me to get you in for an appointment. Plus, then I have to let it express for an appointment cycle, 6 to 8 weeks. You're looking at 3 months. A lot of patients then just are like, okay, I'd go and reshape my anatomy, or yeah, just give me a few active retainers because I have to wear a clear retainer anyway. And I have I have a small space remaining. Okay, I'm just going to build that into an active retainer for you really quickly. For settling elastics, I have found that a lot of people would traditionally use triangle elastics. When you're trying to settle like an open bite, I would say, I found that it is a little bit more predictable to run the elastics on the teeth that you're trying to extrude. it doesn't, I would say, propagate as well as a straight arch wire. So that's why with the overbite correction, I would say I find that the middle one works really nicely. And then most of my patients kind of appreciate not having buttons on their upper front teeth. And I've had every patient that I've ever directed to do this middle one has been able to do it, whether they're young or old. So what you do with this middle one, it's a 3/16 inch light 2.5 ounce elastic. I always tell people you need 2 hands. You're going to use that elastic hook. You put it right up against your palate. Then you use your other finger to push down on the elastic, and then you can pull with the elastic hook to make it taut. So once you have it pulled and stretched out, you just slide it under the IP loop of the upper ones, and then you just bring it down to the lower 2 buttons. As long as I've shown every patient how to do it, sometimes it slides out. The first couple of times they try to slide it under it, they miss. But I always thought, everyone is able to do it within a minute. And then once in a while, though, if the patient doesn't have good hygiene, the incisive papilla of the upper ones is too inflamed, and it's too up against the IP loop of the upper ones. So then I just tell them, okay, you have to go between the upper 1-2 IP loop, and you have to go vertical like this with 1/8 inch elastics. That 3/16 inch is a little bit too wide to go on the upper 1-2 IP loop. This one is a little bit harder to do. But again, I still have found that most patients, whether they're young or old, can do it. They're highly motivated to prevent having buttons put on their front teeth. Because I tell them, if you can't do it, worst case scenario, I just put some clear buttons on the front teeth, on the upper front teeth. And then that works as well, really well as well. And then the other thing that sometimes when you're doing your finishing, you'll find that you're going to get some collisions on your upper anterior brackets. So quite often I'm now debonding the upper arch first to allow for the settling. So I'm just looking usually at the DE in my digital enhancement small design. And then I see in my digital enhancement small design, okay, I'm going to be in collision when this bite's fully settled. So I just take the upper off first. I find that also is just easier on my chair time as well. Take off both upper and lower InBrace actually takes quite a bit of time, chair time. Sometimes it jams up my schedule. So more and more I'm doing single arch debonding. And then I'll just make an upper Essex retainer. If I still needed to run elastics for settling, then you can just add teardrop cutouts or button cutouts, however cutouts you want to do to run the elastics. And then you just run whatever elastic pattern you want. So in this case, I'm still running some class 3 and some vertical. Sometimes I run a box elastic with lower 2 buttons on the lower 2s. And then again, just teardrop cutouts on the upper 1s or the upper 2s. And then when you're ready to debond, usually just grab an angulated debonding bracket remover, grab it from the occlusal gingival, roll towards the occlusal, hold the tooth with your finger to, again, kind of mitigate some of that torquing feeling. Use a throat pack. And then we find that the go-to adhesive makes it a lot easier, the removal, just because now you can see the composite with the black light. I use a round diamond or a round carbide for the bulk removal, and then a rounded white stone for anterior polishing and a flame for posterior polishing. So kind of in summary, I would say the main thing to get out of this is that, to have a very solid, strong foundation of what you're doing in each appointment, as well as like your foundation for what I would say your system is for your clinical approach, which is, going through the stage 1, which again is just bracket position, IPR, small orc 1 expression. Stage 2, let the wires express, run your elastics, remove or reduce the bite turbos, and then digital enhancement, which is finishing, where you're going to be proactive in making a good DE small design, doing your final clinical adjustments, let the wires express, and then running elastics instead of the occlusion. And I would just say that, I would say the nuances again of your treatment, the key nuances to know again, common reason teeth are not moving as planned. Most likely it's either the small design or your brackets are not positioned properly. So a lot of people forget to reposition the brackets that are indicated in the treatment instructions. And then again, also only repositioning brackets that are direct bonded. So we have had providers that will reposition indirect bonded brackets, and that also causes other issues that they weren't expecting. Okay, because a lot of times they get the torque off. Again, minor inaccuracy is acceptable. Major inaccuracy should be repositioned again. Elastic guidelines. A lot of people get mixed up on this. So AP, class 2, class 3 elastics, light in smart wire 1, medium in smart wire 2, heavy in smart wire 3. For vertical elastics, lighten it up again because you're going to just extrude the single tooth if you overpower it. So usually generally nothing in smart wire 1, light in smart wire 2, medium in smart wire 3. Most of the time it's just with smart wire 2, I would say again. When you are ready to take your for DE, make sure your assistants take a good scan where the brackets are clearly visible. Make sure they dry the bracket. And then again, there should be no obstruction. So soft flow bite turbo should be removed or at least reduced. For a posterior bite turbo, at least it should be at least reduced enough that the bite is settled so that you can do your final detailing and final settling in your DE small design. And then when you're ready to finish, again, sometimes the upper arch needs to be debonded first to allow for settling. And sometimes it's just faster also just to reshape the anatomy and use active retainers as needed. Okay, so in our last 5 minutes or so, I can go through any questions. I'll go look through the questions. Let me look through this.
All right.
Okay, so.
Okay, Dr.
Go
Lee,
ahead,
I
Matt. Yep.
got 2 questions for you. The first question is, do you recommend a new bracket if you have to repo?
Yeah, generally we recommend a new bracket. So actually we do provide brackets in the kit. We've just found it's just easier and faster to place a new bracket.
Okay. And here's another question. I'm just going to read it directly from the chat. What's your system for not forgetting those repos? Do you have your assistants flag those repos in the chart as soon as the cases come back?
Yeah, I would just say that I always double check the treatment instructions. This is like the first thing I look at. So it's kind of like I would say with aligners. The first thing I look at with aligners is I look at the ClinCheck. My assistants should have the ClinCheck up on the screen, and then I just double check the ClinCheck and where they're at. So same thing, you have the small design and you have the treatment instructions are in the portal. I have the kit there. So I always just first thing I will do is I will check the treatment instructions. And then I let my assistants know, okay, we're going to direct bond or we're going to direct no bond this at the fitting appointment. And then just being, I would say, proactive with your notes. So anytime I need to direct bond, I'm very good with, I would say, next visit notes for my assistants. I always like to make sure that my assistants can look at the next visit notes and have everything set up by the time I get there. So usually, again, if you have a fairly strong understanding of the stage 1, stage 2, how the wires are going to express, you kind of can predict fairly easily, okay, I directional bonded the smart wire in this appointment. So I know, okay, I'm going to put a bracket on in the next visit. So I usually my next visit note will say, remove the directional bonding, add direct bond to bracket. And then anytime I direct bond to bracket, my next visit note will always say, double check this bracket position. So then I always just double check it.
Okay, that's all the questions that I have. Are there any other questions? You can feel free to. Oh, here's another one. What is your debond protocol for InBrace, especially if planning to order S6 retainers? Digitally remove brackets or place fixed retainers?
So my retention protocol for most of my patients is most of my patients, they chose InBrace over aligners because they didn't want to have to wear retainers full time. Personally, for me, I like to have something on full time for the first 6 months. And then after 6 months, I tell everyone you can go to nighttime wear. So I like to do upper and lower fixed retainers, upper 2 to 2, lower 3 to 3. And then I also provide clear retainers that they wear at nighttime. So I do both. If I do, and then I always tell them after 6 months, if you really don't want the fixed retainers, then I'll take them off for you. But I at least want something on full time. Or if I do an upper 2 to 2 fixed retainer, like say I take the upper off first, what I'll do is I'll do the upper 2 to 2 fixed. A lot of times I actually will digitally remove the brackets prior, and then I'll just cut a window out of the upper 2 to 2 area. And then when they come back for the next visit, I take off the lower, and then we tell them for that visit, you're gonna have to come back later in the day, or you'll come back the next day to pick up the clear retainer. So then I'll make them a new upper and lower S6 retainer.
Okay, one more question. Sometimes in very crowded cases, it is difficult to complete all the IPR at the first visit. Would you recommend having the patient come back sooner than 8 weeks to finish the IPR to prevent the bite opening in front, or is 8 weeks okay?
Yeah, I mean, it just always depends case by case, I would say. So usually in the first visit, I'll try to do a little bit of IPR. I agree. Like if there's a lot of crowding, you can't get everything done. So I'll at least try to loosen the context with an IPR strip, take 0.1, 0.2 millimeters off. I usually find that it's fine bringing back to patients 6, 8 weeks later. If you have a ton of crowding, the other thing sometimes you'll do is you won't fully activate the wire, meaning you don't have to put the wire, you don't have to directional bond immediately. So there are times with a lot of crowding, what I'll do is I actually will leave the wire unligated because I don't want everything to flare forward. I want to give myself more time to do IPR. So then I would say that would be the main thing you would do in that situation.
Okay. It doesn't look like we have any more questions.
Cool. I'd say the last thing is, so we do have more webinars coming up. So next week, we'll be going over the smile design portion of things. And then the following week, we'll be going over case study. So all of this is on Facebook. And it's also been emailed out to you, and it's also available on the Smile Design Studio.
All right. Well, thank you so much for everyone for attending this call. We do, as you can see here on the screen, we do have a series of webinars that we'd love to see you guys attend. May 25th, this one's not on here, but we do have a study club. Love to see you guys there. This is a peer-to-peer learning. It's going to be hosted by Dr. Scott Shorts and Dr. Brian Lockhart, where they'll be sharing some of their cases. They'll be going over what they do when they're setting up cases, and also what their thought process is when it comes to reviewing smile designs. We will also ask anyone who attends this webinar to submit some cases and smile designs that they would like to review with your peers. So that's going to be on May 25th at 5 p.m. Pacific time. Okay, so reach out to TIS and they will get you the registration links.
Great. Okay. Thank you, everyone. And then please fill out the survey as well at the end. That's also very helpful for us.
Yeah. All right. See you guys.
See you, everyone. Bye.